Well, Pertuzumab clearly is a more active drug when added to trastuzumab. It's probably most evident in the metastatic setting, of course, when it got approved in 2012, but also it's clearly achieves a higher degree of pathologic complete responses in the neoadjuvant setting, which again was its first approval in the early stage setting. Now, importantly, in the adjuvant setting, we're trying to prevent recurrences in the first place anyway, and thereby improve survival. So the Affinity trial looked at that group of patients and again showed very convincingly that the addition of Pertuzumab does decrease the number of recurrences. Now, the absolute benefit is actually small, and that probably has to do mostly with the fact that some lower risk patients were included in that study. In fact, anybody with a tumor over greater than 1 centimeter, and for some period of time even between 5 millimeters and 1 centimeter if they had other higher risk features, were able to go on the study. And the criteria were changed a little bit over the course of the study, but in the end it clearly does improve outcomes, and the tolerability is pretty good, probably some more GI toxicities. Doesn't seem to increase cardiac toxicity. It does bring up the issue of cost and something that we have to pay attention to, that as a society, the cost for very low-risk patients may be at a threshold where it's not the best uses of resources, and we always have to rethink that aspect. But from a purely biological and clinical aspect, it is really achieving what we want to do, and that is eliminate or almost eliminate the number of patients that ever recur.